Okay, guys, do you have questions according yesterday lecture?
What, ma'am?
Do you have questions?
No, ma'am.
Guys, did you attend yesterday lecture?
Yes.
So I explained you about the cerebellum and about the basal ganglia, right?
Yes.
Okay, so if you don't have any questions, let's do some MCQs together, okay? About the cerebellum and basal ganglia. Okay, guys, so the first question is the spina cerebellum contains the what contains the spina cerebellum? Okay, let me copy the question in your chat, okay? 1 minute. Okay, guys, this is a question. Hello.
Yes, ma'am.
So please can you read question?
Yes, ma'am. The spinocerebellum contains a vermis and intermediate zone of the anterior and posterior lobes, the vermal and follicular parts of the lobe, condylar lobe, lateral portion of cerebrum, posterior lobe and interpost nuclei, anterior lobe and dentate nuclei. Answer is, ma'am.
Which one is correct answer?
Maybe, ma'am, this the lateral portion of the cerebrum.
Which one? A1, right? Guys, correct answer is A. Vermis and intermediate zone of the anterior and posterior lobe. Okay? Correct answer is A. Okay, next question. The lateral vestibular nuclei are functionally analogous to the red nucleus, Purkinje cells, basal ganglia, thalamus, deep cerebellar nuclei. To which one? Hello. Guys, I hear. Lateral vestibular nuclei, guys.
Which, ma'am?
Which one? B? No, not B. Not B, guys. Muhammad Noman, what do you think? Which one is correct answer? Muhammad Noman. 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 Hello. Hamna, Nasir. What do you think?
Basal ganglia.
Mm-hmm. Basal gang. No, guys. Correct answer is deep cerebellar nuclei. Okay. Why? Because the lateral vestibular nuclei also not contained within the cerebellum, and they are considered to be functional analogies to the deep cerebellar nuclei because of their functional connectivity with the cerebellum. Okay, guys. Okay, now let's do questions. About the basal ganglia. Noman, can you read question, please? Oh, sorry, this without the answer. Just a basal ganglia. Which of the basal ganglia nuclei receive direct cortical input? Guys,
Yes, ma'am.
which one?
Yes, ma'am. Answer is subs is substantia nigra pars compacta and globus pallidus external.
Mm-hmm.
C.
Mm-hmm. No, these nuclei do not receive direct cortical input. Guys, direct cortical input. Do you remember that picture I showed you yesterday? There was direct cortical input. Mm-hmm.
B, ma'am.
Mm-hmm. No, B, incorrect. Mm-hmm. Okay, let's ask another student. Who? Shahid Iqbal.
Ma'am.
Shahid Iqbal. Uh-huh.
E. Caudate and putamen.
Yes, right. This is correct answer. So as you remember, we had there was a direct and indirect pathway, right?
Yes, ma'am.
So caudate and putamen are the only parts of the basal ganglia that receive direct cortical input. Okay, good. Very good. Shahros, right? Your name? Muhammad Shahros.
Yes, ma'am.
Okay. Next question is, wait, please. Shahid Iqbal, can you please read this question? Shahid Iqbal. Hello.
Yes, ma'am. Yes.
Can you please read this question in the chat?
Okay, ma'am. Reading, ma'am.
Mm-hmm. Mm-hmm. Can you read, please? Iqbal? Hello.
Ma'am, can I read?
Yes, you can read, please, Shahroz.
Yes, ma'am. Reading.
Sir, पढ़ दीजिए.
Huh? Okay, please, Shahroz,
Shahid
read.
Iqbal is reading.
Okay, Iqbal, read, please. Uh-huh. Okay, Shahroz, can you please read all of the following
Yes,
statements?
ma'am.
Uh-huh.
All of the following statements about the basal ganglia are correct except first A. The net effect of excitation of the direct pathway to inhibit cortex B. Dopaminergic neurons of the substantia nigra signal unexpected reward or unexpected substance of reward. The basal ganglia have both motor and cognitive function. The subthalamic nucleus is the origin of the only purely excitatory pathway within the basal ganglia intrinsic circulatory. E. Parkinson's disease results from damage to the basal ganglia.
Uh-huh. So every statement is correct except which statement?
G.
A, right, very good. Why A? Because
Because ma'am, the net effect of excitation of the direct pathway is to inhibit cortex.
yes, very good. So it's there is written that the net effect of the excitation of the direct pathway is to inhibit cortex. This is false statement, right? The net effect of
Yes.
excitation of the direct pathway is to excite cortex. Okay, very good,
Because
Shahroz. Because what?
the net effect of excitation of the direct pathway is to excite cortex.
Very good. Yes, right. Very good, Shahroz. I'll put you 5 mark, okay, Shahroz?
Thank you.
Other students sleeping, right? Okay, guys. Now let's talk about the like. If you want to, we can talk about the clinical features of the region of the cerebellum because yesterday we did on the lecture we didn't talk about that. 1 minute. I'll open the PDF. Okay, so here, as you can see, we can read the case. A 13-year-old boy with a lesion in the cerebellum developed gradual worsening headaches, nausea, vomiting, and nystagmus over the course of 2 months. His headaches were worse at night and were mainly in the left occipital area. A neurological examination revealed bilateral papilledema, nystagmus, mildly slurred speech, irregular ataxic movements that were worse on the left side than the right. What causes patient problems? So guys, as you remember, yesterday when we talked about the cerebellum, we said that the cerebellum influence the cortex by the contralateral parts, but the cerebellum was like connecting to the pyramidal system on the ipsilateral side, on the same side, right? So you may think that here you can see that ataxic movements that were worse on the left side than on the right. Then you can see that the lesion is in the left hemisphere of the cerebellum, not on the right hemisphere, okay? According this information that given in this case, okay? Also there was, you can see here, okay? So history
Okay, ma'am.
Ventilate again. Okay, first let's talk about the lesions, okay? What will lead the lesions in the cerebellum? So here you can see clinical correlation, sign and symptoms. So hypotonia, diminished muscle tone, right? So like muscle tone will decrease. Postural changes and alteration of gait. So head is often rotated and flexed. Shoulder on the side of the lesion is lower than on the normal side. Wide base gait, stiff-legged to compensate for loss of muscle tone. Lurch and stagers towards the affected side when walking. As you can see, person will fall to the same side where the lesion is, okay? So, and wide base gait, also we call this like a drunk gait. You may think that the person is drunk, but maybe the problem is in the cerebellum, okay? So like a drunk gait. Ataxia, loss of the coordinated muscular contraction required for the production of smooth movements, okay? So guys, ataxia is different from the tremor because guys, ataxia is the movements will be more wide and for example, in Parkinson syndrome, tremor is increasing when person is resting. In Huntington chorea, tremor like chorea form tremor chorea, right, is increasing when person is trying to perform action. But in the ataxia, guys, ataxia will increase when the person will trying to approach the object, okay? For example, if person trying to touch the nose or maybe take the object, so ataxia will be increased, okay? So in ataxia will be when person is trying to approach something, okay? Dysdiadochokinesia, an inability to make or difficulty making rapid alternating or successive movements. So here, guys, for example, you can check this dysdiadochokinesia. You will ask patient to rapidly do pronation and supination with the hand, okay? And if the movements will be not so like how I can say, if the movements will be uh, how I can say, like movements, guys, must be uh, like exact, okay, and definitive. And if uh, these movements will be not accurate, so you can say that this is problems with the dysdachokinesia, okay? Also will be disturbance of reflexes. Movements produced by tendon reflexes tends to continue for a longer um, period of time than normal, okay? So reflexes will be low, reflexes will be decreased, and there will be disturbance of ocular movements, nystagmus, and disorders of speech. This nystagmus, guys, this is the rapid alternating movements of the eye, okay? And disorders of speech, these are three: ataxia of the laryngeal muscles. So because there will be ataxia of laryngeal muscles, person will talk like scanning speech, okay, guys? There will be like scanning speech. So all words will be like not low, but person will be uh, person will talk loudly, and each word will be not continuous speech. Okay, guys, so it will be like sharp speaking, scanning speech. Mhm. Mm. So as you can see, we have different syndromes. Vermis syndrome, involvement of the flocculonodular lobe result in signs and symptoms related to the vestibular system. Vermis is unpaired and influences midline structures. Muscles, muscle incoordination involve the head and trunk and not the limbs. Why? Because there was the cerebellar, what? Cerebellar. Do you remember, guys? Here I will show you again. There was like a map. Mhm. 1 minute. I am opening. Ah, yes. Topographic arrangement of skeletal muscles controlled by the cerebellum. Okay. As you can see, trunk, head, neck is light on the vermis portion, and arms and hands are light on the hemispheres. Okay, so that's why Vermes syndrome will include the ataxia of the trunk. Okay, that's why. Okay, 1 minute. Oi. Uh-huh. Okay, guys, because of that. So um as you can see, involves the head and trunk and not the limbs. Tendency to fall forward or backward, difficulty in holding the head steady and in an upright position in holding the trunk erect. Okay. Cerebellar hemisphere syndrome, for example, due to the tumor. So usually unilateral and involve muscles on the side of the diseased cerebellar hemisphere. So the site will be same. Movements of the limbs, especially the arms, are disturbed. Swaying and falling to the site of the lesion often occur. Dysarthria and nystagmus are also common findings. Okay, as you can see, falling to the site of the lesion often occur. So common diseases involving the cerebellum: acute alcohol poisoning, congenital agenesis of or hypoplasia, trauma, infection, tumor, multiple sclerosis, vascular disorders such as thrombosis of the cerebellar arteries, poisoning with heavy metals. So guys, actually in neurology, like a lot of cases are causes are the same, okay? So for example, alcohol poisoning, trauma, infection, tumor, poisoning with heavy metals, common causes of other disorders also, okay? Now let's talk about that case. So a 13-year-old boy was brought to the pediatrician office because of 2 months progressive left occipital headaches, nausea, slurred speech, and nystagmus. The patient was well until 2 months previously when he began having headaches, which we initially attribute to a sinus infection, right? So sinusitis. Headaches gradually worsened, with headache mainly in the left occipital area and sometimes accompanied by nausea and vomiting. but no visual changes. Headaches were worse at night and in the early morning hours. His teacher noticed that over the past few months he had some difficulty concentrating and learning new material at school. During the week prior to presentation, his mother noted increasing gait instability and mildly slurred speech and decided to bring him to pediatrician. Okay, so physical examinations, temperature, pressure, respiratory rate, blood pressure you can see here, neck supple, lungs clear, heart regular rate with no murmurs, abdomen soft, non-tender, extremities normal. Guys, so do you have neurology classes? Did they start neuro classes?
Yes, ma'am.
So now I think that you already learned, right, um, about the physical examination, right? Or
Yes.
neurological examination. Okay, so mental status. Alert and orientated, speech fluent with normal repetition and comprehension, cranial nerve pupils equal round and reactive light, visual fields full, they had blurred disc margins. Bilaterally, extraocular movements were full, but there was horizontal nystagmus. On lateral gaze, bilaterally vertical nystagmus on up gaze, worse than down gaze. In addition, the vestibulo-ocular reflex was not fully suppressed by visual fixation. Facial sensation and corneal reflexes intact, face symmetrical, hearing intact to whisper bilaterally. Mm, Speech slightly slurred and with an irregular rate. Normal palate movements and gag reflex. Normal sternomastoid and trapezius strength. Tongue midline motor. No drift. Normal tone 5-5 powers throughout. As you can see here, the reflexes are normal. Uh, okay, so guys, what about the coordination? As you maybe you already learned on your NIRA classes that we have a finger to nose test when person trying like raising to the side hands and then trying to approach with the finger to the nose with the index finger. Okay, so mark dysmetry on finger to nose testing. Worse on the left is approximately 2 inches of error. Also, dysdiadochokinesia, inaccurate rapid alternating movements, worse on the left side. Heel to shin movements were taxic on the left, but normal on the right. Heel to shin, guys, one person is trying to from laying on the bed, okay, and with the heel, like making smooth movements, okay, on the shin. So gait wide based with feet approximately 2 feet apart, unsteady, staggering to the left, unable to perform tandem gait. Romberg test with feet 4 inches apart, there was no worsening. So guys, here, as you can see in this case, the problem is in the cerebellum, okay? So this is infectional disease that, guys, so what do you think? On the basis of the symptoms and signs mentioned above, where is the lesion? As you remember, the problems was on the which part, guys? On the right or on the left side of the body in this case?
Left side.
Yes, on the left side. So where is the lesion, guys? I already just now I showed you the topographic arrangement, and as you remember, if the problem is in the vermis, it will affect which parts of the body? Hmm? Guys, hello.
Yes, ma'am.
So the problem was on the left, right? As you remember, we divide to the Vermes syndrome and hemisphere syndrome. So which syndrome is this in this case? Vermes syndrome or hemisphere syndrome?
Hemisphere.
Yes, right, exactly. Why hemisphere syndrome?
Because, ma'am, this is the sign obstruction in the blood
Mhm.
vessel.
Because the problem was in the hand and the legs, right?
Yes.
But trunk and head was normal. So the lesion is in the left hemisphere of the cerebellum.
Yes.
Guys, and what is the most likely diagnosis? Mhm. So as you remember, there was infection, right, in his sinus,
Yes. Ma'am.
in the sinuses, right?
Yes.
This is in the history.
Yes. Ma'am.
Previously, sinus infection. So, what is the probable diagnosis? That also,
Sinusoid.
uh-huh. So here, right, guys, infection or some infection disorder, some in the cerebellum. Okay. Mm, yes. Okay. The probable diagnosis is that maybe they didn't treat this infection. Okay. Uh, so this is like complication, okay, guys, of the sinusitis, okay. Okay, so this is what cerebellum, mm, cerebellum clinical signs. Oh, now let's talk about the clinical signs of the extrapyramidal system. Mhm, mhm. So as you remember the functions of the basal ganglia, function of the basal ganglia in motor control, basal ganglia involved in the enabling of practice motor acts and engaging the initiation of voluntary movements by modulating motor programs stored in the motor cortex and elsewhere in motor hierarchy. So thus, voluntary movements are not initiated in the basal ganglia, they are initiated in the cortex, right? However, proper functioning of the basal ganglia appears to be necessary in order for the motor cortex to relay the appropriate motor commands to the lower levels of the hierarchy. So, guys, this is a disorder of basal ganglia. Dyskinesia, involuntary movements, okay? Resting tremor, most often associated with Parkinson's disease. So, when patient is at rest, certain body parts will display a 4-7 hertz tremor. For example, the thumb and forefingers will move back and forth against each other in a characteristic tremor called pill rolling tremor. Also, for example, in Russian literature, it's calling not pill rolling, it's calling like coin, like person is calculating the coins in the hand, okay? So tremor stops when the body part engages in active movement, okay? Etetosis is characterized by involuntary breathing movements, especially of the hands and face. Chorea, which derives from the Greek word for dance, characterized by continuous breathing movements of the entire body. So it is viewed by some as an extreme form of etetosis. Chorea is most closely identified with Huntington disease or with the chorea minor, okay? So Huntington disease is a genetic disease, and chorea minor is a children disorder. It's like complications after the uh, juvenile arthritis, okay? Ballismus is characterized by involuntary ballistic movements of the extremities, and tardive dyskinesia can result from the long-term use of antipsychotic drugs that target the dopamine system. It is characterized by involuntary movements of the tongue, face, arms, lips, and other body parts. It is thought to occur as a result of an imbalance between the D1 and D2 receptors, thereby favoring the direct pathway over the indirect pathway. And also, guys, we have another disorders which are included mm, in the chorea's disorders. Okay, so there was tics, pallismus, tardive dyskinesia, etetosis. Okay, Huntington disease, chorea minor. So that's why we call akinesia, guys. So as you can see, kinesia, guys, from Latin or Greek word, I don't remember. It means like movement, okay? A word here which means absent, right? So absent of movement. So akinetic syndrome is a Parkinson syndrome, okay? But hyperkinesia, guys, is about the Huntington disorder, okay? Chorea, ballismus, tics, and all other disorders. So also an akinesia will be rigidity, okay? Coccygeal rigidity or lead pipe rigidity. There will be dystonia and bradykinesia. Bradykinesia, guys, this is the slowness of movement, okay? Bradymimia, slowness of movements of the face, face expressions. Okay, guys, so do you have questions? Hello, guys, do you have questions?
No, ma'am.
Is everything clear?
No, ma'am. Yes, ma'am.
Okay, guys, so if you don't have any questions, class is over, okay? I will put 5 mark to Muhammad Shahroz. Other students, you will do module on your website. Okay, guys?
Okay, ma'am. Thank you.
Okay, bye.